Hello and welcome to Best of the Day from the 2015 Great Debates and Updates in Hematologic Malignancies. We're meeting once again in New York City this year at the beautiful and historic Waldorf Astoria Hotel. And the first day of the meeting is usually kicked off with a half-day program on multiple myeloma. There have been tremendous advances and evolution in the understanding of the biology of multiple myeloma, as well as therapies and new targets over the past 10 years. So I'm meeting this afternoon with Dr. Ruben Nisvinsky from the Weill Cornell Medical College, and we're going to talk about some of the presentations and some of the debates that took place earlier today. So Ruben, welcome to Best of the Day. Thanks so much for being with us.
Thank you.
Well, multiple myeloma has always, to me, been one of the most interesting diseases. And I guess the fact that there's such an obvious marker with the monoclonal protein, the disease manifestations are often fascinating. And even when we just had melphalan and prednisone, we were able to help people for a number of years. But now with the IMiDs and the proteasome inhibitors, and all the other agents coming along, it's really been a dramatic and phenomenal time for multiple myeloma docs like you. So Sagar Laniel kicked off the session this morning talking about monoclonal antibodies. And Ken Anderson always liked to say that we're looking for a vitamin R for multiple myeloma, a rituximab that will do as much for myeloma as rituximab has done for lymphomas. So I know there are a number of monoclonal antibodies that are fairly far down the clinical trial pathway, and then there are others that are a little further back. So tell us about the agents that you think we might have available in the clinic within the next year or two.
Sure, let me paraphrase. First, the issue with the multiple myeloma, it was a very exciting time when we see those new agents coming in as the outcomes of patients have improved so much. I still remember practicing when we had very limited amount of options, and now we have an explosion of new agents, different classes, and that has really changed the outcome for patients. I have to say that as being a myeloma doctor, I have learned that the myeloma care requires not only excellent internist, but also now he requires a molecular biologist, an immunologist, and hopefully we'll be able to cure this disease soon.
That's the goal. The
newer agents have revolutionized the care of myeloma to the point in that some key opinion leaders are starting to doubt the need for use alkylating agents or high-dose alkylating agents. So there is going to be a controversy that's being addressed by clinical trials in the need of autologous stem cell transplant, which is an important question to ask. Within the newer agents, of course, we have the immunomodulating drugs and we have the proteasome inhibitors, but the most exciting is the advent of a new class of drugs that can help us augment the efficacy short-term and long-term, and those are the monoclonal antibodies. Several antibodies have been tested in the past, and there's always the challenge that the cells shed their antigens, and the typical target for these cells would have been the idiotype, right? If the cell is an IgG kappa, why not have antibodies against the heavy chain or the light chain? The problem is that these cells shed that, and the target becomes a difficult one.
Right.
Similar, other antigens are shed, like beta-2 microglobulin and other ones that end up being challenging to target. On that context, CD138 Syndecan-1 was one of the first targets to think about because of its limited expression in the rest of the organs, only CNS and other ones. But the problem with that molecule is also that it's shed. However, most of the myeloma cells do express these antigens, and now there is trials looking at this not as a naked antibody, but rather as immunoconjugate. And although as a single agent activity shows no great promise, in combination with immunomodulating drugs, it appears to show very interesting responses. So I would really look closely to that.
So is CD138 internalized after it's bound by the ligand?
As I understand it.
Yeah, and so that sucks the rhabtansine into the cell and
Exactly.
kills it. Very good. So what about the CD38 antibodies?
CD38 was neglected, particularly with the fear that will target other non-immunological cells, such as smooth muscle or mast cells. And therefore, it was the development of that antibody was delayed. However, we're very excited about daratumumab and the Sanofi molecule SAR that will target that moiety. And as for the first in time, we see that these type of agents can display single agent activity. The response rates have been dramatic, even in patients with relapse and refractory disease. We can start to see patients in certain clinical trials in which we can actually combine them with immunomodulators or proteasome inhibitors. And so we are to the way to find the final R-CHOP for myeloma. Okay. So it could be daratumumab with an immunomodulator, or could be the SAR molecule with an immunomodulator. And those are displaying very interesting response rates.
And then one of the first antibodies we began hearing about a few years ago was Elotuzumab, which used to target CS1. Now they changed the name of it to SLAM-F7.
Correct.
And that drug is in phase 3 trials now.
What is very interesting is that drug did not show single agent activity.
Right.
And yet, when combined with immunomodulator, it enhances efficacy dramatically. So we are awaiting the results of the ELOQUENT trial, in which compares lenalidomide, dexamethasone versus Elo, lenalidomide and dexamethasone in the relapse setting. And that will be very informative to see what is the value of this monoclonal antibody. I have said from my personal experience, I have seen very good outcome on patients receiving this molecule.
Very good. I think hopefully within the next year or two at the most, we're going to have some of these drugs approved and available in the clinic.
I hope so too.
So one of the questions that I think is asked frequently is how many drugs are necessary in combination. And for years it was melphalan-prednisone, and then we had combinations like MPT and BMP. And so in the patients that are considered transplant ineligible, and the age cutoff has gradually risen from like 60 or 65 now well into the 70s. So when in your practice, how do you make the decision as to whether or not a newly diagnosed patient is transplant inappropriate, I guess would be a better term. And then how do you decide whether you're going to treat that patient with a 2-drug combination or a 3-drug combination?
The decision to transplant or not to transplant is more related with the performance status and the frailty index. And I think there is a lot of variability among institutions of how to define who's frail, who's fit, and who's unfit. And there is a recent algorithm set up by Dr. Palumbo in which tries to define this group more appropriately. But using the geriatric population, or the data from the geriatric literature, we like to use a comorbidity index based on our own Cornell-based Carlson index. And we try to look at other factors such as albumin and performance status to define the subgroup of patients who would be candidates for transplant or not. The other decision that is made to decide whether it's a transplant candidate or not is indeed the response, because I don't see transplant as a goal, but rather I see complete remission as a goal. And I'm of the school of thought that the deeper the response is, the better is the outcome. It used to be said that only 30% of the patients will have those type of outcomes, but as the therapeutics have evolved and changed, we are seeing deeper and longer remissions, and it's all a matter of finding the right combination. So the decision of transplant or not will depend on the results of ongoing trials in which asking particularly that question, the need of transplant or not. But in general, those patients who are frail will not be a candidate for transplant.
So in somebody, a 78-year-old gentleman who you would not consider to be truly fit, but is symptomatic with newly diagnosed multiple myeloma, we know that you published a study several years ago, the Upfront study, looking at several bortezomib-based combinations, and then the first trial was presented at ASH a year and a half ago now, looking at lenalidomide, low-dose dex versus MPT. What are you doing in your practice for those patients who, are not fit and are somewhat frail and older?
Generally, we look at other factors, not only the age or the frailty. I think the best combinations should be lenalidomide, dexamethasone, or bortezomib, dexamethasone. And I make that decision depending on renal function, and other psychosocial aspects of the patient, the ability to come to the clinic. Some economics have to be taken care of. Since we don't have a randomized trial between RD and VD, I don't have any more information than everything that surrounds the patient, such as the renal function, peripheral neuropathy, etc. Now, it's important to notice in the argument in the elderly people that those who argue that the more is better, VMPT followed by VT, which is brought by Dr. Palumbo, the advantage of that regimen was not the 4-drug regimen that was talked upon in the meeting today. It's actually the maintenance.
The maintenance, right.
Because when you compare VMPT with maintenance versus VMP without maintenance, the winner is not the induction, the winner is the maintenance.
I agree completely.
And that's what the lenalidomide dexamethasone continuously proves in the first trial, in which compares MPT to lenalidomide dexamethasone at 18. The big difference, the split of the curve, occurs exactly at the time that maintenance is started.
Right.
The same happens when MPT is tested against MPR or other regimens. The lenalidomide maintenance is what continues the response. So in the elderly population, I think more than important than the induction, which is important and we all aim to achieve a complete response, is more important than maintenance therapy.
Well, that's a great segue into one of the other debates that was held later this morning, and the duration of maintenance. So should maintenance, like in lymphomas, rituximab is given for 2 years in maintenance in non-Hodgkin's lymphoma. Is there a limit if you're going to use lenalidomide? Should you use it for 2 years, or should you use it until disease progression? Do you make that decision based on cost, the development adverse events, convenience to the patient, the level of their response, or how do you decide that?
Well, I wish I had a clinical trial or evidence base to define this question. I don't have strong phase 3 data to support whether 2 years is inferior or as effective as continuously vis-a-vis the efficacy and toxicity, long-term toxicity, and pharmacoeconomics will be also important to consider. Based with that disclaimer, I have the gut feeling and the gestalt that continuous therapy is continuous therapy, and I don't favor limitation of therapy. Based on indirect data from the relapse and refractory setting, in which when it's limited, curves join. In other words, you see a separation of the Kaplan-Meier curves when you're giving the long-term therapy. If you at one point stops, the curves meet again. So that has to be taken in consideration with other aspects, of course, the toxicity, the secondary primary malignancies, and the economics of that. But in the best of the worlds, I would always offer continuous therapy to our patients.
So if patients are beginning to run into difficulty with cumulative myelosuppression, do you give them a break for a few months and then restart?
Well, we follow the guidelines of whatever drug we're going to be using. So if we're using lenalidomide, we follow particularly the guidelines offered by the package insert.
Right.
And that's pretty helpful. With bortezomib, there are 3 different regimens of maintenance. One never tested against each other, but we can use bortezomib weekly, 4 out of 6, so that allows you a 2-week break. There is another regimen that is given every 2 weeks, so that also gives a break. And there is another regimen that you can give the full course of biweekly bortezomib, days 1, 4, 8, and 11, and then you do it every 2 to 3 months. I wish there would be randomized data to show which one of those bortezomib regimens would be superior.
In some patients, especially higher risk patients, are you combining lenalidomide and bortezomib in maintenance?
Indeed.
Very good. All right. Well, then let's finally talk about some of the other novel agents that are making their way through the clinical trial process. We know that the oral proteasome inhibitors have been around for several years now and are looking very interesting, especially ixazomib. And then there's the kinesin spindle protein inhibitor, the array drug. I don't know if it even has a name now.
Filanesib.
Filanesib, right. And so there are several other agents. Some of the BCL2 drugs are being looked at. Tell us, what you think are the most important novel agents coming along.
But certainly the oral proteasome inhibitors will open a new window how to treat patients with multiple myeloma, particularly the elderly group, and the long-term maintenance. So that's a very important addition to the armamentarium against myeloma. Ixazomib, the boron-based proteasome inhibitor, is now past most of the early phase 3 trials, and now we're waiting to see the maintenance trials. We're participating in post-transplant and also in the non-transplant candidates. So we're very excited to see the outcomes of patients receiving ixazomib, particularly those with high risk. Because if you can actually use a proteasome inhibitor in the high risk to prolong their outcome would be fantastic.
And how is that drug tolerated long term?
It's very well tolerated and capitalizes on the same benefits that the sub-Q Velcade was giving, in that the major activity is not at the peak, which causes most of the neuropathy, but rather the area under the curve and the continuous use.
And what about the oral epoxy ketone drug, the oprozomib?
The oprozomib appears to be more potent. Of course, this needs to be randomly compared. However, has some challenges in its GI tolerance. We are working in trying to define the better dose and the better schedule, and appears to have found a proper dose in the current phase 1 trial in combination with the immunomodulators. So we are very excited of also participating in those trials. It's still a challenge to see what's going to happen later, but at least I think we have found the proper dose, the most tolerable dose.
And then what about the Filanisib? What role do you see for this kinesis protein inhibitor?
Yeah, so I have been very surprised about the tolerance of this agent. In other words, the toxicity profile is very good, and it allows to be used in a biweekly, every 2 weeks pattern without corticosteroids. And in patients who are relapsed and refractory and have gone through the heavy doses of corticosteroids, it's a very nice alternative. There is a subgroup of patients that respond much more, and the company is working on finding a biomarker that can help us define ahead of time which patients are going to be responsive.
That would be helpful.
The only major toxicity appears to be neutropenia, which is very easily managed with growth factors.
Very good. Anything else that you're excited about as far as novel agents?
The HDAC inhibitors initially were very promising, particularly in the ability to modulate protein catabolism. The problem is that the toxicity of the agents and the lack of specificity precluded proper dosing. Example of that is the advantage in weeks that was seen in the randomized trial of vorinostat bortezomib, which unfortunately did not get approved because of its toxicity profiling. We're very excited about panovinostat that has been now approved, and that will open the opportunity to use it in an earlier stage, because if you see that trial, the CR rate was much higher in the combination of panovinostat and bortezomib versus the bortezomib alone. So even if you're not using it long term, it can help us in the induction regimen.
And how well is panovinostat tolerated?
It appears to be well tolerated. There is some GI toxicity too, but it can be managed. Dr. Richardson presented in this meeting also the ASH report of RVD plus panovinostat, which is a very interesting combination as a quadruplet for the induction regimen.
And then Paul also talked about the HDAC6 inhibitor, roclinostat, or something, I think.
Ricolinostat.
Ricolinostat, okay. And how far along is that agent?
Well, there is a new oral presentation that appears to be effective with a very well toxicity profile. So we're working in that in collaboration with other myeloma centers.
Very good. Ruben, thank you so much. This has been very interesting. It's been a great meeting. I am going to let you go back to work.
Thank you.
All right. Thanks so much for being with us. And thanks to all of you for watching this segment of Best of the Day from the 2015 Great Debates and Updates in Hematological Malignancies. There is more to come at this meeting, talking about leukemias with David Steensma, and then lymphoma discussions with Dr. John Leonard. So be sure to check back with us. Thanks again.